in its own right. But it's part of the Department of Immunology. And Anne Holland was appointed a couple of years ago, a year, and has done an absolute fabulous job at leading respiratory research at Alfred, and really taking it to the next level, as well as doing extraordinary things with her own career, which has been recognised by international societies and otherwise. So I'll hand over to Professor Holland to introduce the speakers.
Thanks very much, Terry, and great to see everyone here and online. It's great to have this opportunity to talk about the work that we're doing in respiratory research. I would also like to acknowledge the Boonwurrung and Wurundjeri clans of the Kulin Nation, who are the custodians of the lands and waters, and pay respects to elders past and present. So I thought I might just take a couple of minutes at the start to talk a little bit about who we are and what our structure is, because it is a bit different to many of the other departments here. We actually sit within the Department of Immunology and Pathology. That really reflects the stellar leadership over many years of Professor Robin O'Hare, who was in this position before me, who had a very strong track record in immunology, and hence that relationship endures. So we have, of course, a very close relationship to respiratory medicine at Alfred Health. That is one of the largest departments of respiratory medicine in the Southern Hemisphere, with a huge range of clinical conditions, particular interest in end-stage lung disease and lung transplantation as well. So we're very fortunate to be working alongside that clinical department. So within respiratory research at Alfred, we have two groups of clinical researchers, one led by myself and the other led by Associate Professor Natasha Smallwood, who you'll hear from a little bit later today. And we also have a very strong relationship with the Allergy and Clinical Immunology group, which is led by Professor Menno van Zelm, with obvious alignment there around our research interests. And across all of those areas, we have a lot of involvement in clinical trials, and also our teaching and education program that goes across all areas. So in terms of our interest in our team, we have a very broad research portfolio. Of course, clinical trials is a big part of that. We do not only drug trials, but also device trials and trials of models of care. We've got interest in both quantitative and qualitative methods. We've got quite a depth of experience in qualitative methods within our department, which I think has been a real asset. Also, evidence synthesis. We've had strong relationships with Cochrane Airways for a very long time, and have generated a lot of the Cochrane reviews that are governing our practice in respiratory. And also registries, increasing interest in cost effectiveness, particularly with the work of Angela Burge, and interest in implementation science, and we're often ably supported in that by Professor Tash Lannon, who's in the room today. So there in the middle, I've put some of the areas of interest for our research. We have a strong interest in improving access to care for patients with respiratory disease, developing new models of care for those people that need them. Non-drug treatments, including things like rehabilitation and oxygen therapy, and the interest in symptom management and palliative care. We are a very multidisciplinary team, and I think that's been one of our assets. You can see there the disciplines who are involved in the research that we do. I may have left some off because there's a lot of different people who are involved in our work, and that's been, I think, a really great way to get many different perspectives and think about research differently by including all of those groups of people. I just wanted to take a moment now to say congratulations to our first speaker, Dr. NARELLE COX, who's recently been awarded an NHMRC Investigator Grant for the next 5 years. It's, of course, as we all know, an incredibly competitive process, so I just wanted to acknowledge that stellar achievement from NARELLE. So after that, I'm going to hand over to NARELLE, who's going to tell you about some of the work that she's done and where things are heading in the future. So I'm going to stop sharing our screen so NARELLE can share hers. And while she's doing that, I will introduce her. So Dr. NARELLE COX is a physiotherapist, and she's a senior research fellow in the respiratory care group here at the Central Clinical School. And she's currently the Lung Foundation Australia inaugural John Farrell Fellow for COPD research. She completed her undergraduate and master's degrees from the University of Sydney and was awarded her PhD in 2014 from La Trobe. Her research focuses on improving health and clinical outcomes for people with chronic respiratory disease through physical activity and exercise rehabilitation, includes exploration of telemedicine and technology-based strategies to promote pulmonary rehabilitation access and physical activity participation for people of all ages with chronic respiratory disease. And as I said, NARELLE will be presenting remotely today. So over to you, NARELLE. Thank you.
Thank you very much, and for the opportunity to be able to tell you about some of our work today. I was actually very much looking forward to being able to do something like this in person, but like everything good to look forward to over the last 3 years, COVID has put paid to that as well. So hopefully remote will do the justice today. I too would like to take a moment to acknowledge the Boon Wurrung and Wurundjeri clans of the Kulin Nations from where we come to you today, and to pay my respects to their elders past, present and emerging. As Anne has already highlighted, I work as a part of the Respiratory Care Research Group within the wider respiratory research at Alfred Group. And collectively, the goal of our work is to improve the lives of people with chronic respiratory disease through the development and investigation of novel drug treatments and optimal supportive care. The reason we do this is because nearly 1 in 3 Australians suffer from a lung or respiratory condition, and those individuals experience debilitating breathlessness, reduced physical capacity for daily activities, and recurrent flare-ups or exacerbations of their lung disease that regularly require hospitalisation. To that end, there's also substantial costs incurred not only to the individuals with respiratory disease, but also to the health system. For people who experience chronic obstructive pulmonary disease, or COPD, annual bed costs in Australia exceed $530 million, and the number of COPD-related hospital admissions are expected to double within the next decade. So pulmonary rehabilitation is the primary non-pharmacological treatment which is recommended for people with chronic lung disease. It's a program of exercise and education designed to improve symptoms and function and reduce the risk of exacerbations and need for hospitalisation. To be considered pulmonary rehabilitation, a program must comprise certain essential components as set out by the American Thoracic Society. And this includes things like an initial assessment, which is to be undertaken in the centre or the hospital. And these kind of assessments need to encompass things like exercise or physical capacity, quality of life and nutritional status. Programs need to be able to deliver both endurance and resistance training that is individually prescribed for patients and is progressed according to standard protocols, and that it's delivered by individuals who are suitably qualified to be able to do those sorts of things. In an Australian context, pulmonary rehabilitation is typically delivered in an outpatient setting, and programs tend to be of 8 weeks duration, with people coming along to the hospital or community health centre for 2 sessions per week, and these are usually between 1 and 2 hours in duration. We have robust evidence for the benefits of pulmonary rehabilitation, particularly in people with COPD, as well as increasing evidence for people in other groups with chronic lung disease, including those with interstitial lung disease, bronchiectasis and pulmonary hypertension. The evidence of effect that we have of pulmonary rehabilitation for people in COPD is such that Cochrane have taken the unusual step of closing the review topic because they felt that further randomised controlled trials comparing pulmonary rehabilitation to conventional care, which is no rehabilitation, were no longer warranted because they were unlikely to change our confidence in the estimate of the effects that are seen. And so it's on the back of this robust evidence that we have both local and international clinical practice guidelines for the delivery of pulmonary rehabilitation and clinical treatment guidelines which recommend referral to pulmonary rehabilitation as part of the management for people with chronic respiratory disease. So on the basis of all of that, you'd be welcome to think that we would be beating people back at the door who are trying to come and do pulmonary rehabilitation with us. But unfortunately, that's not quite the case. Globally, there are insufficient programs to be able to serve the needs of all of the people who would benefit, and there are a number of very well documented and significant barriers that patients in particular face to being able to access these traditional outpatient models of care. And primarily these revolve around issues with travel and transport to be able to attend a centre to undertake a program, as well as dealing with the presence of comorbidities, and for many of our patients, conflicting demands associated with caring and work responsibilities. And so it's because of these many barriers that work was being undertaken to be able to find alternative ways to deliver pulmonary rehabilitation. And this is where our tale of telerehabilitation begins. And in this context, we're considering telerehabilitation is the delivery of rehabilitation services at a distance, making use of information and communication technologies. And it's important to note that a lot, and plenty of the work that we're talking about today, all was undertaken or started in a pre-pandemic world because of the particular barriers that we've already highlighted. And importantly, that the kinds of communication technology that's made use of for delivering remote rehabilitation services does not just solely rely upon video conferencing. One of the starting points of this work from our group was a model of home-based, remotely delivered rehabilitation, making use of the telephone, which was developed by Professor Holland, and which has been determined to achieve equivalent clinical outcomes to traditional program models, but at much higher completion rates. And this particular model of telephone-based rehabilitation delivery has been part of usual care here at the Alfred since 2016, and was one of the early pieces of work which was at the forefront, if you like, of our increasing interest of remote delivery of programs within the pulmonary rehabilitation world. As a result of this, we undertook a Cochrane review in order to evaluate the effect of telerehabilitation programs, and we found that remotely delivered pulmonary rehabilitation is able to achieve similar outcomes to that which is achieved with the traditional centre-based models. And this is for outcomes of importance, including exercise capacity, which is demonstrated on the forest plot, as well as for quality of life and symptoms, without any additional safety concerns for participants. And in the Cochrane review, when we looked at the included studies that had a predefined minimum level of program adherence in order to classify participants as program completers, we can see on the Cates plot that for every 100 people, more are able to complete a program of telerehabilitation, shown in the green, than are able to complete centre-based pulmonary rehabilitation. And presumably this is in part due to overcoming some of those challenges to program access that we touched on earlier. However, one of the things with our Cochrane review is that the certainty of evidence at this point in time still remains small, although I predict that future updates of the review will have much more content in it as a result of the last couple of years. And as well, the number of participants included in the studies was relatively small. Another of the factors that impacts the findings of the Cochrane review is that, or the certainty of the evidence, was the number of telerehabilitation models that have been investigated and were included in that review. So the review encompasses studies of 5 different models of telerehabilitation delivery, and this highlights further that video conferencing is not the only way for these programs to be delivered. And the included studies in the review demonstrated remote delivery using methods including the telephone, via websites, making use of text messaging, video conferencing, or mobile applications. And as a result, we currently have insufficient evidence to be able to identify if there is one model of remotely delivered rehabilitation that is better than another. The review also highlighted for us some other gaps in our current evidence base, and this includes things around whether rehabilitation models delivered using video conferencing are able to achieve equivalent outcomes to the gold standard or traditional centre-based model. What is the effect of making use of consumer devices as opposed to specialist or bespoke equipment? Whether these programs are effective in patients who are not in stable health, because to date all of the included studies in the Cochrane review were undertaken in people with stable health, as well as understanding the economic benefits and costs of these kinds of programs to support their long-term infrastructure and training. And so some of the next work that I'm going to highlight is trying to address some of those gaps. So this is the rehabilitation exercise at home, or the REACH trial, which was a multi-site randomised controlled equivalence trial which was conducted at 4 sites, 3 of them here in Melbourne and 1 rural site in Western Victoria. We recruited 142 individuals with a variety of chronic respiratory diseases, and they were randomised to either undertake the traditional 8-week centre-based pulmonary rehabilitation program or an 8-week home-based program of telerehabilitation, which included twice-weekly sessions supervised in real time via video conferencing, And participants were provided with a kit of equipment that was readily available from any store that you could walk into. So we provided them with a consumer grade exercise bike, an iPad with data enabled to be able to undertake the video conferencing, and an oxygen saturation monitor so we could monitor them throughout their exercise training. And at the conclusion of the overall trial, there were no statistically significant differences between groups for any of the outcomes at either end rehabilitation or at 12 months of follow-up, and importantly, both groups achieved clinically meaningful outcomes at the end of their rehabilitation period. Whilst we weren't able to confirm equivalence of telerehabilitation for changes in symptoms, we were able to confirm equivalence of telerehabilitation for improvements in exercise capacity gains, which are the two right-hand graphs shown here. And in fact, we were unable to rule out superiority of telerehabilitation for improvements in exercise capacity. And so as a result, whilst we couldn't say that telerehabilitation was equivalent to centre-based pulmonary rehabilitation for all outcomes, we were able to determine that a model that includes real-time supervision of exercise training is certainly safe and achieves clinically meaningful outcomes, meaning that it could provide an alternative program model when centre-based programs aren't available. And of course, this became much more pertinent to us over the last couple of years with COVID-related restrictions. So we were fortunate enough to be able to take that REACH model of telerehabilitation delivery that included supervised exercise training and implement that into clinical practice here at the Alfred in September of 2020, at a time when centre-based programs weren't able to be undertaken. And this slide represents for you the beginnings of the process evaluation that we've been undertaking over that period of time, so that we can provide some real-world evidence for the implementation of this kind of model into practice. And in that period of time, 21% of all people who've been referred to pulmonary rehabilitation have undertaken telerehabilitation, and those participants have achieved significant and clinically meaningful improvements in key outcomes that are of a magnitude similar to that which was seen in the main trial. Interestingly, the breakdown of diagnostic group for the participants in the real-world implementation has been slightly different to the clinical trial, with more individuals having interstitial lung disease than what we saw in the main trial. Of course, real-world adaptations have been required from our more controlled clinical trial setup, including the fact that participants need to be able to have access to their own Wi-Fi to be able to undertake telerehabilitation in the clinical model. And as well, 40% of the participants that have taken part thus far have provided some component of their own equipment needs. So be that their exercise training equipment, a bike or a treadmill, or an internet-enabled device on which they can undertake the video conferencing. If we refer back now to those gaps that we highlighted from the Cochrane review, another area was that all of the trials to date included in that review were in people that were in stable health. And so we're undertaking a 5-site randomised control trial to see whether remotely delivered pulmonary rehabilitation, and this time using the telephone-based model, is suitable for people shortly after discharge from hospital for a respiratory exacerbation, to see whether we can improve both access to rehabilitation at that time and have an impact on all-cause hospitalisation over 12 months. And one of the challenges for this particular trial, that one of the, if you like, core things that underpins this particular trial, is not only about supporting access to rehabilitation, but about getting the timing of it right as well. And the reason that this is important in what we're referring to as our early home-based trial is that we've got evidence that pulmonary rehabilitation, when it's undertaken early after an exacerbation, can actually achieve even greater benefits than those achieved by people in stable health. But the timing of when this rehab is undertaken relative to the exacerbation is quite pertinent, with studies which have undertaken or commenced their rehab period during the inpatient admission not demonstrating benefit versus those where rehab commences after discharge being the ones that demonstrate benefit. So these factors tie together for us to indicate that getting rehab access after discharge from hospital is important. But of course, one of our big challenges with access is that fewer than 3% of people with COPD actually attend an outpatient centre-based rehabilitation program within 12 months of hospitalisation. So we're hoping that, given the previous success of the telephone-based model in supporting increased completion of rehabilitation, that we will be able to achieve similar outcomes by providing that model of care to people shortly after a hospital discharge. Of course, this particular trial, while still ongoing, started all of about 8 weeks before the COVID pandemic really took off. So it remains to be seen how successful we will be in a slightly different world. Some of the other areas where we're trying to support increasing access to rehabilitation services for our patients is around increasing capabilities. And as we've touched on previously, there are not enough services on a global scale to support those who need it. But as well, over the last couple of years, we've seen increasing demand for changing the way those services are delivered in response to COVID. And underpinning some of this is information that came to us via a website that we have, and this website is set up to support clinicians to be able to deliver that telephone-based model of rehabilitation. And the graph here that you can see on the right, unsurprisingly, indicates the spike and increase in traffic we had to that website from March of 2020, such that from March 2020 till the end of that year, we had more than 23,000 page views for clinicians seeking ways to support their ability to deliver remote rehabilitation. We also had many contacts from clinicians all around the world, and the key things that they were trying to seek further information about was how to overcome implementation barriers for delivering such remote rehabilitation programs, and also how they could suitably assess their patients remotely, particularly with respect to exercise capacity, which again ties back to that need to be able to competently assess patients in order for programs to actually conform to being pulmonary rehabilitation. Added to this, early on in the pandemic, our group undertook a rapid review to be able to determine what, if any, exercise tests there might be that could either be conducted safely by patients in their home environment, or better yet, supervised remotely, that would enable us to adhere to this core component of rehabilitation delivery. And unfortunately, or fortunately, the review found for us that whilst remotely supervised exercise tests are possible in selected groups of patients, the available data is very limited, and most of the tests that people have been administering in a home environment for their people with chronic respiratory disease aren't actually able to reveal the full extent of desaturation that becomes evident on walking or endurance training. And to date, none of the home-based delivered tests or remotely delivered tests have been validated for the prescription of exercise training intensity. So you can see here there are a number of factors that are contributing to either an ability or an inability to be able to successfully deliver a true program of pulmonary rehabilitation remotely. So this has led to some current work, which is still continuing as well. The first of which is a hybrid implementation trial, which is designed to understand the barriers to implementation of remotely delivered rehabilitation across different healthcare contexts. And this has been supported by seed funding from the Australian Academy of Science. And to date, we've completed focus groups and interviews with clinicians in New Zealand, the US and India. And on the basis of this process, are working on developing an online resource which will be able to transcend different healthcare contexts to support some of these higher tech levels of remote rehabilitation delivery. Concurrently with that, we're also looking at ways that we can support remote assessment of exercise capacity, which would truly enable us to deliver the entirety of a pulmonary rehabilitation program remotely. And so in order to do that, we're evaluating whether a standardized exercise test, which is known as the modified incremental step test, which we know can be delivered in or administered in the patient's home, and also is able to determine for us extent of desaturation and from which we can prescribe exercise training intensity. And we're looking to see whether we can accurately and safely conduct this same test supervised remotely via video conferencing. So we're undertaking a cohort study to compare the outcomes of in-person testing versus remotely supervised exercise testing in this way. So on the basis of a lot of that, you might be thinking, remote rehab for everybody. No one needs to come to a centre anymore. We should just do everything via digital or telephone. And Unfortunately, that's not quite the case, and I think one of my important things to always convey, despite the fact that a lot of my work is around how do we deliver rehab remotely, is that it doesn't take away from the traditional model, which is still our gold standard for delivering this kind of care. And some of the reasons that we can't just do away with the traditional model is that people with COPD perceive that they will receive better quality of healthcare when they engage with a health professional in person. As well, more than 30% of people who are eligible for pulmonary rehabilitation don't actually have access to a device or the internet for which they could receive such a remote service. And it's important to note that of those who do have access to the right kind of device, nearly half of them access the internet for less than 1 hour per week. And this is important because those people that access the internet for that little time never choose a virtual or a web-based option as being preferable to them. Depending on which report you read over the last couple of years, up to 55% of patients are still preferring to wait for face-to-face rehabilitation services rather than select or undertake any kind of remote option. But it's not all terrible news, because of those who do actually start a remotely delivered model, 80% found it to be easy or very easy to be able to undertake in that way. So I think that highlights for us as well, we've still got some work to do in supporting patients to be able to feel confident and comfortable to be able to undertake these remote kind of programs. So to finish up, certainly, and I hope, because it's the work that I do, remote delivery of pulmonary rehabilitation will be an ongoing component of therapy delivery for people with chronic respiratory disease, but we need to remember that it isn't for everyone. We have some, but we need more evidence of real-world effectiveness, particularly to ensure that we have adequate infrastructure and training, but also how best we adapt our clinical trial models into the real-world setting so that we can include all people who are referred to pulmonary rehabilitation, and not just those that agree or meet strict eligibility criteria that exist in a clinical trial. We need sustainable funding models and infrastructure and training to be underpinned by solid economic analyses in order to be able to justify the ongoing costs associated with some of these programs. And there are still things that we need to find out in terms of long-term outcomes, and perhaps ideally if there is one best kind of rehabilitation model for a particular kind of patient. And just to finish again, I'd just like to acknowledge our group as a whole, who are all contributors to all of this kind of work. Thank you very much.
Thanks very much, Narelle, and thanks for coming today, and we're very glad that your voice held out for the entirety of that talk, so that was a stellar effort. Thank you, and fortunately we will be able to spare you questions, because I'm sure your voice is needing a rest now, so thank you. So we're now going to move on to our second speaker, who is Associate Professor Natasha Smallwood. Associate Professor Smallwood is a respiratory physician at the Alfred Hospital and head of the Chronic Respiratory Disease Research Lab at the Central Clinical School. She's a Principal Research Fellow at Monash University. In addition to her respiratory qualifications, she holds postgraduate qualifications in epidemiology, palliative care, and medical leadership. She has authored over 90 publications and holds various major research grants, including an NHMRC investigator grant. She has clinical and research interests in breathlessness and severe lung disease, and she's going to tell you about some of those today. She also established and leads a specialist integrated respiratory and palliative care clinical service, and she's passionate about gender equality and health leadership. So welcome.
Thank you very much, Anne, for that introduction, and also for the invitation to present today. It's always that slight stress when you try and get your technology to work. So, as Anne's highlighted, our research in respiratory medicine is really, really growing, and I guess it's a really exciting time to be at Monash and the Alfred doing the kind of research that we do. But the other thing to really note is the amount of synergy that exists between the different teams that we have. So while I'm going to talk about severe lung disease and palliative care, there's an awful lot of overlap that happens between our different teams. There's a lot of collaboration, and there's a bit of overlap with some of what Narelle's just been talking about as well. So I'm going to talk a little bit about why it's challenging to care for people with severe lung disease, some of the research that we've done in that space, and some of the current research that we're doing. And when giving a talk like this, it's quite challenging actually, because you have to decide what you want to pick from all the different things that you could talk about. So it was quite a hard decision. So I don't want to sort of duplicate what NARELLE was saying, but for my research team, what we're particularly interested in is chronic obstructive pulmonary disease, interstitial lung disease. And I may be a respiratory physician, but I like dabbling in looking after people with heart failure. And that's really because actually there's an awful lot of overlap in the people that come to see me with COPD who also have heart failure. So I'm very fortunate to have a good collaboration with a cardiologist. And so we have actually done research in heart failure and end-of-life care, but I'm not going to present any of that today. But as you can see from this slide, COPD and heart failure are both extremely common. They lead to lots of admissions and they also lead to lots of death. And they cost the health system an awful lot of money. And we really haven't been able to make much change to that over many, many years. Interstitial lung disease is much less common, but is becoming more prevalent as we get better at diagnosing it. But the real challenge with interstitial lung disease is the incredible palliative care needs that this group of patients have, and the very poor prognosis they have if they've got fibrotic interstitial lung disease. So we know that people with these different types of condition have really difficult, distressing physical symptoms, and I'm going to highlight some of those in a moment. And as Professor Holland noticed, my particular interest is actually in severe breathlessness. But it's not just physical symptoms that these patients have. They often have really immense psychological needs. They get very lonely and socially isolated, which contributes to poor quality of life. There are some real issues around stigma and shame, particularly related to smoking in people with COPD. And we know that they have quite profound information needs. So often by the time someone comes to see me, they've actually attributed their symptoms to old age, when obviously it's actually related to chronic lung disease. So there's a lot of distress, there's a lot of suffering. And unfortunately, the reality is we don't have great treatments for COPD and interstitial lung disease. And actually, research on palliative care and supportive care in these two population groups is really still in its infancy. So for COPD, we've been doing research in this area for about 20 years. For interstitial lung disease, that's more like 5 years. So those physical symptoms are really, really critical. So most people with advanced COPD will have a combination of breathlessness, cough, and fatigue. And this is despite us giving them optimal disease-directed care, whether that's inhaler therapy, pulmonary rehabilitation, oxygen, and so on. So we know that actually patients have persisting ongoing symptoms, often for many years prior to death. And that the average symptom burden is 11 symptoms in the last year of life. So there's this real mismatch that we provide great disease-directed care, but we often completely fail to address the symptoms or even recognise the symptoms that our patients are experiencing. And that symptom profile is actually very similar in heart failure and interstitial lung disease as well. So a few years ago, there was this paper that came from Europe where they really highlighted the complexity of needs for patients with interstitial lung disease, but this equally applies to people with COPD, and highlights that we actually need to get the diagnosis right. We then need to give them good disease-directed care. We need to provide symptom relief, and we really need good holistic care. But most of this, frankly, doesn't happen. And one of the real challenges for people with COPD and interstitial lung disease is that supportive care has traditionally been provided on the basis of prognosis. So if we think you're going to die, you'll probably get palliative care. But if we base palliative and supportive care actually on needs as opposed to prognosis, actually more patients would access optimal treatment. But the problem is that is not what happens in clinical practice. So for people who don't know what palliative care is an approach for patients and their families who have a terminal illness, which aims to improve quality of life. And there are many different domains that are encompassed within palliative care, so addressing physical symptoms, psychological symptoms, psychosocial support, and obviously dealing with existential distress. And there are several studies around palliative care, particularly from cancer, that show that it actually does lead to improved outcomes for patients and their caregivers, but also reduced inappropriate care and reduced costs. But we know that since we've had specialist palliative care, which has been around since the 1950s and recognised really as a specialty in its own right for the last 20 years, that the usual clinicians have stepped away from providing palliative care, that it's seen that we don't have the capacity or the knowledge or the experience to provide this level of care to our patients. And so potentially by having a specialty, we've actually disadvantaged our patients. And yet we know that these patients need this type of care much earlier in their illness course, concurrently with their disease-directed care. And one of the other things that is challenging when thinking about current palliative care models that contributes to the problem is that palliative care was designed for people with cancer. So the focus is on people who are high functioning for a long period of time, who suddenly deteriorate and death is quite prompt. So those models focus on the last 6 weeks or potentially the last 6 months of life. And obviously in someone with COPD, that's not actually appropriate. So the model isn't quite right. The community sadly still thinks that palliative care is where you go to die and are really reluctant to see someone who is called a palliative care specialist. I kind of get that. I wouldn't want to have to see one just yet. And again, because we've got so many different actors involved in delivering this very complex type of care, care actually becomes quite fragmented. And I just want to highlight this because this is this concept about illness trajectory. And in the top dotted line, this is how our patients with lung cancer track, that they usually track actually incredibly well, particularly with some of the new drug therapies we've got. But when they deteriorate quite quickly. So it's actually very predictable. And those needs will escalate over those last few weeks of life or last few months of life. And so it's very easy to put palliative care in for those patients and to prepare them for what's going to happen. Whereas in the yellow line that you can see where patients are exacerbating, perhaps they've got COPD, ILD or heart failure, any one of those exacerbations could lead to death. What generally happens is that people decline over many, many years, and that can be 10 or 15 years. So again, if we're thinking about prognosis, we will completely fail to recognise that patients need supportive care. And the last thing I just want to highlight is not only do we have problems with the model of care, we don't actually have any great treatments. And this is a real challenge. So this is a table that's taken from the American Thoracic Society policy statement on palliative care and severe respiratory illness. This was published this year. And I'm quite proud to say that I'm the only Australian on that authorship group, and I wrote the section on breathlessness. So I feel that I can quite happily say that in this policy statement, we very clearly came out saying there really aren't great treatments. And the evidence base actually for those treatments for breathlessness in that top line are extremely limited. So in terms of disease treatments, we only have opioids. And in fact, the evidence base for opioids is becoming clearer through our latest systematic reviews that actually that evidence is extremely poor. And those non-pharmacological approaches come from very small studies. And again, the evidence is really quite poor. So the research that my team does, and again, I really want to highlight that this is collaborative research that involves Professor Holland's team, but also many other people, really tries to explore all of that and really focuses on understanding what are we currently doing in terms of providing care for patients with COPD, ILD and heart failure. Is that care equitable? Can we develop new models of care? Are they feasible? Can we put them into primary care as well as secondary care? Can we develop resources to train health professionals to support them? Can we develop resources for patients? And most importantly, to some extent, can we actually have some new treatments? Because as I just highlighted, we really don't have very good symptom management approaches. So at the moment, we're actually running research studies in all of these areas. And I guess when you think about trying to do research in this very fragmented system, it's really important to highlight that actually that research needs to span multiple domains. So it needs to obviously focus on the patients and their caregivers and what they want and need. It needs to consider secondary care, primary care and community, and recognise that there is a complete disconnect between these types, these areas in the healthcare system. So in terms of my research team, we've been doing research and we've completed some of this research already with patients and their caregivers over some years, looking at what do they actually understand about their illness? Can they manage the healthcare system? What are their psychosocial needs? And we're still doing some ongoing research in that area. Do patients want to receive palliative care, and how best can we provide it, and what resources can we develop? And in the secondary care space, we've already completed research looking at clinician attitudes to palliative care, what resources they need, what types of end-of-life care are currently available, and how integrated care can be helpful. I'm going to show you some of that data in a second. And at the moment, we've got some clinical trials running, looking at some new different treatment options, and I'm going to tell you about 2 of those. More broadly, though, this is an area that we've started exploring more, is around health equity, and whether that's actually the disadvantage that our patients in rural and regional areas experience, or whether actually it's related to gender, which there's some really interesting emerging evidence about the disparity in accessing palliative care if you're a woman versus a man. Who would have thought it, but it's there. And also around socioeconomic status as well, and how that influences the ability to access supportive care. And the final domain where we're doing some research at the moment is in primary care. And primary care is almost like the holy grail for doing research in COPD and ILD, because actually that's where most of the patients are. So most patients don't ever come and see a specialist, and very few will come to see a palliative care physician or ever come to a clinic like the one I run. So really working with primary care is quite critical, but actually incredibly difficult to do for many different reasons. So we have done some research around attitudes to managing patients and palliative care in primary care, and I'm going to show you some of those results in a second. We're currently doing a study looking at breathlessness management and what resources we could do. And the one in blue is the one that I would kind of really like to be able to do if we get a $2 million MRFF grant, which is where we aim to do a mixed methods randomized control trial, implementing a new breathlessness intervention into primary care throughout Victorian, regional and metropolitan centres. And as part of that, we'll do an implementation evaluation. And that's a really exciting piece if we get funded, because we're doing it in partnership with some collaborators in the UK who managed to get £2.5 million to do it. So it would be nice if we could get funded too. So I'm going to tell you a little bit about what we found so far around supportive and palliative care. So this is some data from some research done a couple of years ago now, looking at patients with COPD and ILD. And these patients were identified because they died in hospital. So for the COPD patients, we looked at COPD deaths over 12 years at the Royal Melbourne Hospital and North East Health Wangaratta, because we wanted a regional site. And for interstitial lung disease patients, they came from the Royal Melbourne Hospital and Austin Hospital, and we looked at 5 years of death. So the challenge here is we don't have patients who died in the community, but we know that actually very few do. But looking at hospital deaths, which is where 72% of patients die, what we found was that you can see in the last 2 years of life, so we were looking at these patients, most of whom had actually longitudinal care at these hospitals, had very severe breathlessness. Now that's no surprise, because I've highlighted it's a really common symptom. But they didn't just have breathlessness, they had severe breathlessness. So an MMRC of 3 means you can't walk more than 100 metres, and 4 means you're housebound. So these are people with severe breathlessness. And I can't show you the non-pharmacological data because we couldn't work that out from the notes, so it probably didn't happen. But only 6% of those patients with severe breathlessness accessed an opioid in the last 2 years of life, despite having that severity of breathlessness. And only 18% of the COPD patients accessed any specialist palliative care. And for the ILD patients, you can see they do a wee bit better, better at recognising that those patients are going to die. And as I've highlighted, traditionally palliative care has been based on prognosis. So they do slightly better, but you can still see there's this massive disconnect that these patients do not receive supportive care or palliation for their symptoms. Similarly, if you look in the terminal admission, where they died in the admission. People do a little bit better in the terminal admission. We're actually a bit kinder and we give some opioids. But again, very few of them actually ever see a specialist palliative care physician. And if they do, it's usually in the last 24 hours of life, in which case it's probably a wee bit too late. Does that matter, though, that you don't see specialist palliative care? Not necessarily. If the usual clinician team can provide that care, that's not a problem. But the reality is we know that a lot of them can't, and that there is a real mismatch in confidence and experience in palliating patients. So this data really highlights the problems that we've got, particularly in Victoria, in providing COPD and ILD patients with supportive care. And our data is completely similar to studies from internationally, except perhaps we do slightly better at giving opioids. One of the things that came out of one of those studies is that, unsurprisingly, the access to palliative care in regional areas is much, much worse, and that contributes to that variation in care. We then went on from those studies to do a mapping study where we were trying to understand what palliative care services actually existed in Australia, and whether any of them actually had capacity to care for non-malignant patients or actually had specialist breathlessness or integrated respiratory and palliative care services. What we found is there are about 5 integrated services that exist for the entirety of the country, so this approach is not adopted, and that actually most palliative care services cannot provide care for non-malignant patients, and that's because they're already at capacity. So they don't have the experience and they don't have the workforce. So if we're waiting for palliative care to come in and save the day, we are going to be waiting a very long time. So that brings us to the concept of integrated models of respiratory and palliative care. And this is a concept that's grown overseas and obviously has been of interest in this country for a while. So I ran an integrated service at the Royal Melbourne Hospital for about 10 years, and I've run the one at the Alfred for the last couple of years. And this is about bringing together respiratory and palliative care clinicians and a multidisciplinary team to provide best supportive care for these patients. So this is actually data from the Royal Melbourne Hospital. So it's a prospective cohort study done over 4 years. And at that stage, the service had looked after about 171 patients. And you can see that, unsurprisingly, that service is much more proactive at providing palliative care. So all patients get non-pharmacological education, just under half get opioids. I think that's quite appropriate, actually. I don't think it should be higher than 50% because you do need to individualise how you care for these patients. But I guess what's most interesting is that the majority did see a palliative care specialist in the clinic, not everyone, because I provide palliative care to those patients as well. But what it actually led to was fascinating. So it actually reduced admissions, ED presentations with dyspnea and or a respiratory presentation. And that really was around the fact that they had better coping skills to self-manage their breathlessness. But the other thing that was really quite fascinating, of course, this is a small sample, was that we flipped to that ratio. So at the start, I told you 72% of patients normally die in hospital with COPD, but in this group, and it was a mixed group of COPD and ILD patients and a few bronchiectasis, most didn't die in an acute hospital bed. Through having a supportive service like this, we were able to support patients to die at home, which is what most patients want, or actually with in a palliative care hospice or inpatient palliative care unit. I guess, though, these types of services really do need to be formally evaluated in clinical trials, and overseas some of those clinical trials have really shown mixed data. And again, one of the challenges, what are you actually providing? What's the dose of palliative care and what does that actually look like? But certainly in our own follow-up studies, what we found was that patients were extremely satisfied with this type of care, and they felt more confident in managing their symptoms. And confidence is critical because actually you can't take breathlessness away. What we're trying to do is teach these patients to self-manage. So given that we know that most patients don't access palliative care, it's really important to understand how clinicians manage providing palliation or referring patients on to palliative care. Now, we've done this research in respiratory and palliative care physicians in Australia and New Zealand. We did this research in general practitioners and junior doctors in Victoria. We've also done this research in nurses and allied health, but I'm only going to show you some of the data from the physicians. So the specialists, the junior doctors and the GPs. And what we consistently saw from all these different studies was that there were really diverse attitudes to palliative care. So a lot of people don't necessarily, and these are doctors, don't really understand what palliative care is and don't necessarily support that concept, which is really interesting given that these are people with severe lung disease and quite complex needs. There were very diverse approaches to managing symptoms, particularly breathlessness. So many people were not confident to provide different approaches to manage dyspnea, and many were not prepared to prescribe opioids or had out-of-date knowledge. And really many of those barriers were around lack of experience, and probably the biggest ones around lack of time in training, that unless you're doing this fairly frequently, it is actually very difficult to acquire a knowledge base and a level of confidence that you can manage these patients. But of course, that illness trajectory that I showed you at the start really comes into play as well, that when people base their decision on palliative care regarding illness trajectory, then they really don't feel confident. They don't know when to offer different types of symptom approaches. And the other one, which is really very well recognised, is that many physicians are really worried about taking away hope or being seen as giving up on patients. But the stark contrast to that is we know that most patients actually want this type of care and want us to have these conversations. So again, that mismatch is really important to understand and therefore design services that address that. So I've shown you a little bit about the problem and some of the research that we've done trying to identify those gaps in care and those knowledge gaps and so on. I'm now going to show you something in a bit of a Monty Python way, completely different. I'm going to show you two different studies that we're now currently running at the moment, which are actually now focusing on different treatment approaches and can we do things a bit better. So cranium is a really interesting study for someone who is not a neurologist. So what we know about breathlessness, we actually understand the afferent pathway and the efferent pathway. We understand that actually extremely well and what those drivers are for breathlessness. But what we don't understand particularly well actually is how that sensation of breathlessness is generated within the brain. And what pathways are really involved. So to date, there have been about 25 different imaging-based studies, mostly MRI studies, a few PET, trying to understand how breathlessness is generated and perceived and modulated within the brain. And you can see some of those different areas. So there's the motor cortex, there's the limbic system, the brainstem and the cerebellum. But actually those 25 studies have actually been a little bit inconsistent about which areas of the brain are involved. And one of the challenges in interpreting this data is many of those studies are extremely small. They've measured breathlessness at different time points, so whether it's at initiation, peak breathlessness, or after breathlessness. Most have actually used healthy volunteers, so have not been done in COPD or ILD patients. And the real challenge with most of this is that they don't use exercise to generate breathlessness. And yet in day-to-day life, what patients come with is exertional dyspnea. So we know they're actually looking at it from the wrong way. So they've used anxiety-provoking words to make people breathless, which is an interesting method. They've used carbon dioxide to induce dyspnea and also putting people on a closed limb circuit. So what we know at the moment is very, very limited. So this is a study that one of my PhD students is doing, and this is done in a collaboration with Professor Terry O'Brien, Professor Meng Law, and Professor Andre Legersh's group. So it's actually a really nice collaboration, which we wouldn't have been able to do if we weren't here. And what we're trying to understand is how actually exertional breathlessness is modulated in the brain. So this involves putting people into an MRI scanner, which is slightly claustrophobic, and then making them cycle on an MRI-compatible ergometer. And what we're trying to understand then is which of those regions are involved. Does that differ between different groups? So we're actually looking at elite athletes, healthy volunteers, COPD, ILD, and neuromuscular patients. If anybody feels like coming and doing this and they're a healthy volunteer or an elite athlete, come play with us. And again, what we postulate is that people with chronic breathlessness probably have different areas involved. Now, this is actually a very difficult study to do, partly because of movement artifact, but also actually to measure the right things, because you can only see things once they activate. So we actually have to induce dyspnea and then see what's activated and then actually switching off as the patient recovers from breathlessness. So designing the protocol for this particular study was actually a work in itself to try and work out what we needed to measure at the right time. So this is a really interesting study that Lauren Ross is leading. We are looking for volunteers, so I'm really not joking. If you want to come and take part, please do. So I think this is really important, because actually understanding what areas of the brain are involved is critical for finding drug targets. So at the moment, the reason we give opioids is because mu opioid receptors are present throughout the brain. It's a little bit of a blunderbuss approach, so we really do need more focused approaches for finding new drug targets in the future. We have a few different clinical trials that are running, but the one I want to show you is this one, singing for breathing. And I've gone from neurophysiology to singing, so something quite different, because we like to do really interesting and different things in our research team. So for anybody who doesn't know and doesn't like singing, singing for breathing actually has been a program in the UK for over 20 years to manage patients with chronic breathlessness. It arose partly because, as NARELLE highlighted, there are real challenges getting patients into pulmonary rehab, but also because sometimes you need an alternative. And the initial clinical trials were actually quite interesting. I'm going to show you some of those, but it actually just took off and gained traction because people liked it, as opposed to there being a good evidence base. Why would singing work? Well, it does actually offer some physiological benefits, and it's one of the easiest ways to teach non-pharmacological breathing control to patients. And it's actually one of the easiest techniques that they can use during a dyspneic crisis when they tend to forget everything else you've told them. But also it's quite fun and it's joyful. So it deals with some of those other issues that I highlighted at the start regarding social isolation, loneliness. So that connectivity actually is probably quite critical. And for any cynics in the room, singing for breathing has just been used as a clinical trial in the UK for long COVID and came out actually showing that it did work. So it would be nice to be able to do that here. Now, I'm not going to take you through all of the evidence for why singing for breathing may work or some of the outcomes that have been found. But all I want to highlight is actually the research to date is extremely limited. So there have been several small clinical trials, observational studies, service evaluations, other bits and pieces that have been carried out over the last 20 years. But again, one of the problems with these types of studies is they're so heterogeneous in how they have actually delivered the intervention. So some have done it for 12 weeks. One group in New Zealand offers singing for breathing for a year, which is astonishing to actually get that retention and to be able to fund it. But they also measure really different outcomes. So it's actually very difficult to know, is this a physiological benefit or is this actually just a psychosocial intervention? And that's what we're, that's the domain that's then actually improving for these patients. So more trials have published recently, and the one I think that's of greatest interest is the one at the bottom. This actually just published this year. So this was a randomized control trial comparing singing for breathing versus pulmonary rehabilitation, and it was done as a non-inferiority trial. And what they found that it was not inferior in terms of improving exercise capacity. So NARELLE has shown some fabulous research regarding pulmonary rehab and all its advantages. And one of the great things it can do is improve exercise capacity. But singing for breathing is not inferior to pulmonary rehab. So again, I think it's actually quite interesting around what the physiological benefits are. So at the moment, we're through phase 2, we're now into phase 3, and we're running a clinical trial looking at the benefits of singing for breathing for people with COPD and interstitial lung disease. And in this trial, so people have to have been stable for 4 weeks, they have to have a dyspnea score of 2, so they need to be walking more slowly than people of their own age, and they can't currently be doing pulmonary rehabilitation. What's very novel about this trial is it's entirely online, which was partly driven by COVID, because I got the funding to do this trial quite a while ago and then couldn't because of the pandemic, and singing is an aerosol generating procedure. So we decided in the end, instead of making it a hybrid trial, to put the entire trial online. So patients are either randomized to immediately sing for 12 weeks weekly with a music therapist as part of a group therapy, or to standard care. And because this is the type of patients that actually they want to do it, they're going to feel that they missed out. After 12 weeks, the control group actually gets to do the intervention, and we stop collecting data. But so obviously there are challenges about doing an entire trial online, not least it meant that we actually can't measure any physiological data because we can't do 6-minute walk tests. And as NARELLE highlighted in her talk, actually providing support for these patients is critical around accessing an online program. So in fact, we do have iPads and data plans that we give to patients because nobody is disadvantaged. And members of the research team spend quite a lot of time explaining to these patients how to get online and actually how to stay online. But one of the huge advantages of doing a trial like this online is actually we're now recruiting from around Australia. So I have done a little bit of media promotion quite shamelessly about the trial, and unfortunately the Queen died, which bumped us from being in the age, but that's all right. But so through a radio interview, we actually got 10 patients from New South Wales join this trial. So again, in this post-pandemic world, actually the way we can do clinical trials is really interesting, and how you can recruit from around the Australia. So on that note, I want to end. Obviously, I've shown you quite a lot of information and some quite different types of clinical trials and different types of research that we do in our team. I feel really lucky to work at Monash and to work with Professor Holland, not least because we recently went to the ERS at Barcelona, and together we bought some shoes, or at least she pointed me in the direction of a good shoe shop, and I'm now wearing those shoes, which is quite delightful. So it's actually, you know, a really fabulous research team, and everything I do, I couldn't do without my research team and my much wider collaborators. So thank you.
Thanks very much, Tash. I think we're probably reaching the end, so we might leave questions, but I'd just like to thank everybody who attended today, those who are here in the room and also those who are online, and also to say congratulations to our speakers on the great programs of work that they presented today. So thank you all.